Imagine a disease that affects 1 in 7 people on Earth.
Yeah, that is just a staggering number to even try to wrap your head around.
It really is. And it's actually the second leading cause of disability worldwide. It drains, literally trillions of dollars from the global economy.
Right, and it touches almost every family in some way.
Exactly. Yet the primary tool we use to diagnose this massive issue is entirely invisible. You can't, x-ray it, you can't draw blood to find a specific viral load.
You definitely can't biopsy it and put it under a microscope, which makes it so tough to conceptualize.
Right. So today we are doing a deep dive into the murky, often misunderstood, and just profoundly complex landscape of mental health disorders, and crucially, the evidence-based treatments used to address them.
And it is a diagnostic landscape that really defies our usual medical expectations.
How do you mean?
Well, in physical medicine, we love binaries. The bone is fractured or it isn't. The artery is blocked or it's clear.
Right, it's very black and white.
Exactly. But the human mind, which is interacting dynamically with this incredibly complex environment every single second, it just does not lend itself to neat binary boxes.
No, it really doesn't. And we have gathered a massive stack of sources for you today to try and make sense of this. We're looking at comprehensive clinical summaries, the latest global health statistics straight from the World Health Organization, and
And we're digging deep into the actual evidence-based treatment guidelines, the literal rule books that psychiatrists, clinical psychologists, and therapists use in the field every day.
right. And our mission here, the mandate for today's deep dive, is to go way beyond the surface level.
Because mental health is intrinsically linked to physical health.
Yeah.
They're practically the same system.
Yeah, you can't really separate the brain from the body. So we are going to explore not just the clinical definitions, but the actual mechanisms. We want to understand the neurobiology and the psychology of why these treatments work.
Stripping away the stigma and all that heavy medical jargon to empower you with clear, actionable knowledge.
Okay, so let's unpack this. Because whether you are, say, an educator trying to support a classroom full of students,
Or a parent trying to decipher your child's emotional landscape, which is incredibly difficult.
Absolutely. Or maybe you're a professional feeling the crushing weight of burnout, or just someone looking to be a more informed citizen. Understanding this landscape is vital.
It can literally save lives. And it undeniably makes you a more empathetic, effective member of society.
And empathy really has to begin with precision, right? We need to define exactly what we are and, importantly, what we aren't talking about when we use a term like mental disorder.
That is the perfect place to start. Let's dive right into that definition because we throw psychological terms around constantly in casual conversation.
We really do. Someone might say, I'm so depressed my favorite team lost, or, oh man, I'm having an anxiety attack about this work email.
Right. And while those are valid emotions, a clinical mental disorder, as defined by the diagnostic manuals, is significantly more than just experiencing a bad day.
Or a normal human reaction to stress.
Exactly. The clinical threshold for a mental disorder, or a psychiatric condition, requires a clinically significant disturbance in a person's cognition, their emotional regulation, or their behavior.
Okay, but what's the actual line there? Where does it cross from a bad week into a disorder?
The absolute critical differentiator is that this disturbance must actively impair their daily functioning. It is not just the presence of sadness or worry.
It's a structural barrier.
Yes, it fundamentally halts your ability to go to work, to absorb information in school, or to maintain basic interpersonal relationships.
It's breaking your life, essentially. And when you look at the clinical summaries we've pulled, the sheer breadth of what falls under this umbrella of impairment is just staggering.
It is a huge umbrella. The diagnostic manuals categorize these dysfunctions into several major domains. So you have the mood disorders, which primarily involve affective dysregulation.
That would be like depression, right?
Right, major depressive disorder and bipolar disorder, where the brain's energy and emotional states swing just dramatically. Then you have anxiety disorders. And again, this isn't just nervousness before a test. We are talking about generalized anxiety disorder, panic disorder, and obsessive compulsive disorder.
Right, OCD. With OCD, for example, the impairment is incredibly visible. It's not just, liking a clean desk or being organized.
No.
It's being physically unable to leave your house because your brain is firing a false alarm that you left the stove on, and that alarm won't shut off until you check it 40 times.
That false alarm is a perfect way to describe the mechanism. The brain's threat detection circuitry is misfiring. And then the spectrum branches out even further into psychotic disorders, like schizophrenia.
And those involve a break from shared reality, right? Like hallucinations or delusions.
Exactly, or highly disorganized thinking. We also have neurodevelopmental disorders, which encompass autism spectrum disorder and ADHD.
And we also see personality disorders, right? Like borderline or antisocial personality disorders, which involve rigid, unhealthy patterns of thinking and behaving.
Yeah, and there are substance-related and addictive disorders too, plus trauma and stressor-related disorders, with PTSD being the most prominent one there.
Right. And finally, neurocognitive disorders like dementia, where the primary issue is a physical, progressive decline in cognitive function and memory.
Looking at this massive spectrum, it's a lot to take in.
It really is. So I want to try and anchor this in a physical analogy.
Okay, let's hear it.
If we imagine our brains as highly advanced computers, is a neurodevelopmental disorder like ADHD or autism fundamentally an issue with the base operating system we're born with, like the actual hardware wiring?
I follow you, yeah.
Whereas a trauma-related disorder like PTSD, is that more like a highly destructive malware program that gets downloaded later on due to a catastrophic external event?
That biological analogy actually holds up really well. Neurodevelopmental disorders are intrinsic. They dictate how the brain's neural networks form and prune themselves from the very beginning.
So it's built in from day one.
Exactly. ADHD, for instance, involves structural and functional differences in the prefrontal cortex and dopamine pathways. That is your hardware wiring. It's generally a persistent condition.
Meaning it doesn't just go away.
Right. It shapes how the brain processes every single piece of information it encounters from childhood onward. Dementia is also persistent, though it operates in reverse. It's the slow degradation of hardware that previously functioned well.
Usually due to the buildup of specific proteins, right? Like amyloid plaques.
Spot on.
Mm-hmm.
But the malware conditions, as you call them, the mood disorders, the trauma disorders, those behave differently over time.
They're highly episodic, right?
Yes, major depressive episodes, bipolar manic episodes, or acute psychotic breaks, they can flare up with devastating intensity and then recede.
So they come and go in waves.
They often follow a relapsing and remitting course. A person might suffer a severe depressive episode, receive targeted treatment, recover fully, and function at a really high level for a decade before encountering another episode.
So they aren't in a persistent state of clinical dysfunction their entire lives.
Exactly.
Yeah.
Which makes the global statistics we have from the World Health Organization all the more complex, because we are trying to measure something that constantly fluctuates.
But even with that fluctuation, the numbers are just difficult to comprehend.
What's fascinating here is the sheer scale of the WHO data. As of their 2021 global health metrics, they estimate that roughly 1.1 billion people worldwide are living with a mental disorder,
Let that sink in. 1 in 7 people on the planet.
with anxiety and depression holding the top spots globally.
I want to push back on the clinical data for a moment, specifically looking at the United States.
Sure.
The CDC indicates that about 23% of adults, nearly 1 in 4, have some form of mental illness in a given year.
The massive portion of the population.
It is. But the youth statistics are the ones that really made me pause. Roughly 20 to 21% of children and teens have a diagnosed mental disorder.
Yeah, the pediatric data is intense.
And almost half of all adolescents will experience a disorder by the time they reach age 18. I mean, if half the adolescent population is meeting the criteria for a disorder, at what point are we just pathologizing the normal human condition?
That's a very fair question.
Are teenagers just naturally volatile and we are, I don't know, slapping a clinical label on puberty?
It is a vital, ongoing debate within the psychiatric community. It really is. But the data defending these diagnoses brings us back to that core criteria we talked about: impairment.
So it's not just regular teen angst.
No, the teenagers captured in these statistics aren't just experiencing teenage angst or bad heartbreak. They are failing out of school because their executive function is completely collapsed.
Oh, wow.
They are engaging in severe self-harm. They're paralyzed by panic attacks that literally mimic cardiac events. Yes, adolescence is a volatile developmental window. The brain is undergoing massive structural remodeling, particularly in the prefrontal cortex. But the dysfunction we are measuring goes far beyond typical developmental turbulence.
So it's a real measurable roadblock.
Mental disorders are actually the second leading cause of disability worldwide, precisely because they strike during these crucial formative years and halt a person's trajectory.
So if this is a fundamental widespread reality of the human condition, and we accept that it is causing severe, measurable impairment, the next logical question is, What is actually causing these complex neural networks to misfire?
Well, we have to completely discard the idea of a single cause. There is no isolated depression gene. There is no single virus you catch.
Right, it's not like getting the flu.
Exactly. Mental disorders are multifactorial. They emerge from a complex, dynamic collision of genetic predispositions, neurobiological factors, and environmental stressors.
Let's break those down because that's a lot. When we say genetic predisposition, we don't mean you inherit schizophrenia the way you inherit, say, blue eyes.
No, not at all. You inherit a susceptibility. You might inherit a genetic profile that makes your specific neural pathways slightly less efficient at processing dopamine.
Or maybe a nervous system that is naturally more reactive to threat.
Right. That is your biological baseline.
But the baseline alone doesn't guarantee the disorder. The clinical summaries place an enormous emphasis on the environmental triggers, the physical world interacting with the body.
That interaction is everything.
The sources list things like adverse childhood experiences, physical or emotional trauma, and systemic issues like deep poverty, exposure to violence, and severe social isolation.
And it's not just the extreme events. They also list compounding everyday pressures, toxic relationship dynamics, crushing academic expectations, or chronic work pressure.
So how does that actually work? If we connect this to the bigger picture of how human biology actually works, we have to talk about epigenetics, right?
Yes, epigenetics is crucial here. It's the study of how your behaviors and your environment can cause changes that affect the way your genes work. A person might have a genetic vulnerability to anxiety, but if they grow up in a stable, highly supportive environment, that genetic sequence might never fully activate.
But if they were exposed to chronic, unrelenting stress.
Then the environment literally reaches into the cellular level. Chronic stress floods the brain with cortisol, which is the primary stress hormone.
And cortisol isn't inherently bad, right? It wakes us up.
Right, in short bursts, it's a survival tool.
Yeah.
But over time, a constant cortisol bath can alter the expression of genes in the hippocampus, which is the brain's memory and emotion center, causing it to physically shrink.
Wait, literally shrink?
Literally shrink. At the same time, the amygdala, the fear center, can become hyperreactive and grow larger. The chronic environmental stress basically pulls the trigger on the loaded genetic gun.
Thinking about how cortisol physically reshapes the brain really dismantles that incredibly toxic, pervasive societal myth that mental health struggles are just a sign of mental weakness.
Or a lack of willpower.
Exactly. The clinical evidence makes it undeniable. These are medically recognized conditions driven by observable biological and environmental interactions.
You would never tell someone with a broken leg to just walk it off, or tell someone with diabetes that their pancreas is just not trying hard enough.
Yet, we do exactly that with mental health all the time. People experiencing severe clinical distress are told to just stay positive or stop overthinking it or be strong.
It's incredibly dismissive.
Yeah.
And it causes people to ignore the physical alarm bells their own bodies are ringing.
So if we want to be practical about this, what are the actual early warning signs of that impairment that people actively ignore? Because I think a lot of people don't realize their stress has crossed the line into a clinical pathology.
The transition from normal stress to clinical pathology is generally marked by intensity and duration. Sadness is normal. But a warning sign of a depressive disorder is a pervasive, heavy emptiness, or anhedonia.
Anhedonia? What is that?
It's a total inability to feel pleasure. Things you used to love just feel dead to you, and that feeling does not lift for weeks, regardless of external circumstances.
Wow. And what about anxiety? Worrying about a presentation is normal.
Right. But clinical anxiety is a physiological state of hyperarousal that paralyzes you. It can trigger a cascade of autonomic nervous system responses, like a panic attack, where you genuinely believe you are suffocating or having a heart attack.
The guidelines also highlight drastic changes in baseline physical behavior.
Yes, tremendous changes in sleep architecture. Either hypersomnia, sleeping 14 hours a day and still feeling exhausted, or severe insomnia, where the brain just refuses to downregulate into sleep.
And appetite changes too, right?
Drastic changes in appetite. Uncharacteristic irritability or sudden bursts of rage, which is highly common in male depression, though society often misreads it as just anger or a bad temper.
And what about the physical complaints? The text notes that psychological distress often masks itself in somatic or physical symptoms.
The mind and the gut, for instance, are deeply connected via the enteric nervous system and the vagus nerve. Over 90% of your body's serotonin is actually produced in the digestive tract.
Wait, really? 90% is in the gut.
Yep. So severe depression or anxiety frequently manifests as chronic, unexplained stomach aches, digestive issues, tension headaches, or generalized chronic pain.
So your body is literally carrying the distress.
Exactly. When these physiological and emotional symptoms persist for weeks and begin tearing down a person's ability to function at work, school, or home, the line has been crossed. At that point, professional evidence-based support is no longer just a good idea, it is a medical necessity.
Okay, so if the environment has pulled the trigger and the brain's chemistry and structure have been altered, how do we physically get in there and rebalance the scales? Are medications actually fixing the hardware or just masking the alarm bells?
That is the big question.
That brings us to the first part of our treatment toolkit, pharmacotherapy, the medications. Let's look at the primary classes detailed in our clinical summaries.
The foundation of pharmacotherapy for many mood and anxiety disorders rests on antidepressants. The most ubiquitous are the SSRIs, selective serotonin reuptake inhibitors, like sertraline or fluoxetine. We also use SNRIs, which target both serotonin and norepinephrine.
These are considered first-line treatments. But I want to understand the mechanism here. How does a pill actually change an emotion?
To understand an SSRI, you have to look at the synapse, the tiny gap between two neurons in the brain.
Okay, picturing a gap.
When a neuron fires, it releases neurotransmitters like serotonin into this gap to send a signal to the next neuron. Once the signal is sent, the first neuron reabsorbs the leftover serotonin. This is called reuptake.
So it's basically the brain cleaning up the chemical messengers after they've done their job.
Exactly. But in the depressed or severely anxious brain, this signaling is inefficient. An SSRI works by blocking that reuptake process.
So it stops the cleanup.
Right. It forces the serotonin to stay in the synaptic cleft longer, increasing the likelihood that the message gets passed along successfully to the next neuron.
But the clinical literature says antidepressants often take 4 to 6 weeks to actually change a person's mood. If the pill stops the reuptake immediately, like within hours, why does it take a month for the patient to feel better?
That is one of the most fascinating mechanisms in psychopharmacology. It turns out simply floating more serotonin in the brain doesn't instantly cure depression. The current neurogenesis hypothesis suggests that the increased serotonin gradually promotes the growth of entirely new neurons and synapses in the hippocampus over the course of several weeks.
Oh, wow. So it's actually rebuilding the brain.
Yes. The medication isn't just a chemical band-aid. It is slowly prompting the brain to rebuild its own compromised infrastructure.
That is incredible. And SSRIs are just one tool. What about when the mood isn't just suppressed, but wildly oscillating, like we see in bipolar disorder?
For bipolar disorder, we rely on mood stabilizers. Lithium is the historical gold standard here.
How does lithium work?
Its exact cellular mechanism is incredibly complex, but it essentially acts on the second messenger systems inside the neuron, calming down the hyperexcitability of the synapses. It prevents the massive destructive swings between manic highs and depressive lows. We also use anticonvulsant medications, which were originally developed for epilepsy because they also have a stabilizing effect on neural activity.
And for disorders that involve a break from reality, like schizophrenia.
For those, we use antipsychotics. The clinical texts focus on second-generation or atypical antipsychotics like risperidone or quetiapine.
And what are they targeting?
These primarily work by blocking dopamine receptors in specific pathways of the brain. The dopamine hypothesis suggests that an overactive dopamine system is what drives hallucinations and delusions. By dampening that specific dopamine transmission, we can quiet the psychosis.
The final major class mentioned in the texts are the anxiolytics and the stimulants. Let's touch on those.
Sure. Benzodiazepines are fast-acting anxiolytics. They enhance the effect of GABA, the brain's primary inhibitory neurotransmitter.
Meaning they slow things down.
Exactly. They basically slam the brakes on the central nervous system, which is highly effective for stopping an acute panic attack in its tracks. And for ADHD, we use stimulants like methylphenidate.
Wait, using a stimulant to treat a hyperactive disorder seems completely counterintuitive. Why would you give a stimulant to someone who is hyperactive?
It does sound backwards until you look at the mechanism. In ADHD, the prefrontal cortex, the part of the brain responsible for focus, planning, and impulse control, is actually understimulated.
Oh, I see.
It doesn't have enough dopamine or norepinephrine to stay awake and regulate the rest of the brain. The stimulant wakes up the prefrontal cortex, allowing it to finally take the steering wheel and calm the person's behavior down.
Here's where it gets really interesting to me. Reading through the prescribing guidelines, you realize that psychiatric pharmacology is not like handing out aspirin for a headache.
No, not at all.
It's less like turning down the volume on a radio and more like trying to change the flow of traffic in a massive city by only adjusting the timing of a few stoplights. It is a massive cascading system. The guidelines are filled with intense warnings about side effects and contraindications.
It is a high-wire act of precision medicine. The clinician must have a holistic understanding of the patient's entire biology.
Give me an example of how that goes wrong.
Let's go back to SSRIs. If a doctor prescribes an SSRI to a patient presenting with deep depression, but that patient actually has an underlying undiagnosed bipolar disorder, the flood of serotonin can accidentally trigger an intense, full-blown manic episode.
So the medicine designed to lift the depression accidentally overshoots the runway and causes a totally different crisis.
Exactly. Or look at lithium. It is a profoundly effective drug, but it has a very narrow therapeutic index.
Meaning the dose has to be perfectly dialed in.
Yes. The difference between an effective dose and a toxic dose is incredibly small. A patient on lithium requires regular blood tests to monitor their kidney and thyroid function, because long-term use carries significant risks of nephrotoxicity, kidney damage, and hypothyroidism.
The warnings around benzodiazepines and valproate in the text are equally severe.
Benzodiazepines carry a massive risk of physical dependence and severe withdrawal symptoms. They're generally recommended only for short-term acute crises. Valproate, the mood stabilizer, is highly teratogenic.
Teratogenic.
It disrupts embryonic development, leading to severe birth defects. A physician cannot prescribe it without knowing if the patient is pregnant or planning to become pregnant.
This level of risk management clearly requires a strong alliance between the doctor and the patient. But the clinical guidelines go a step further. They specifically emphasize that this complexity requires culturally sensitive treatment plans. We aren't just treating biological machines, we are treating humans within a cultural context.
A vital point, because the efficacy of a medication is zero if the patient refuses to take it.
Wow.
In many cultures and communities, there is deep-seated stigma or profound historical distrust surrounding Western psychiatric medication. Some patients may strongly prefer traditional community healers, natural remedies, or faith-based interventions.
So a doctor can't just mandate a pill and walk away.
A doctor cannot simply hand over a prescription for an antipsychotic and expect compliance. They have to navigate those cultural beliefs with respect, explain the biological benefits in a way that aligns with the patient's worldview, and collaborate with the family to find a hybrid approach they are comfortable with.
Which naturally brings us to the second pillar of the multimodal treatment approach. Because even if you get the medication perfectly dialed in, if the SSRI is promoting neurogenesis and the lithium is stabilizing the synapses, pills don't teach skills.
That's a great way to phrase it.
Medication can raise the floor so you aren't drowning, but it doesn't teach you how to swim through the psychological stressors of life.
Medication modulates the biology, but psychotherapy restructures the cognition and behavior. The evidence unequivocally shows that for most disorders, the combination of pharmacotherapy and psychotherapy yields the most robust, long-lasting recovery.
So let's decode the alphabet soup of psychotherapies in the clinical guidelines.
Yeah.
We constantly hear CBT, DBT, EMDR. What are these therapies actually doing mechanically?
Let's start with cognitive behavioral therapy, or CBT. It is the most widely researched and utilized intervention, considered first line for depression, anxiety disorders, and OCD.
But CBT isn't just lying on a couch talking about your childhood.
Right. CBT is not just venting about your week to a sympathetic listener. It is highly structured, active work based on the premise that our thoughts, feelings, behaviors are inextricably linked.
How does that actually play out in a session?
CBT teaches you to identify cognitive distortions. For example, catastrophizing the automatic belief that the worst-case scenario will inevitably happen.
Like if I fail one test, my life is over.
Exactly. If you fail one math test, the cognitive distortion tells you that you will fail out of school, never get a job, and end up destitute. This thought triggers severe anxiety, which leads to the behavior of avoiding schoolwork entirely.
So how does CBT fix that loop?
CBT teaches the patient to physically intercept that thought, subject it to logical evidence, and consciously choose a different behavioral response.
And by repeatedly choosing a different response, you are actually rewiring the brain.
Precisely. It utilizes Hebbian learning, which is the neurobiological principle that neurons that fire together wire together. By consistently practicing new thought patterns, you physically strengthen new, healthier neural pathways, letting the old destructive anxiety pathways weaken from disuse.
That makes so much sense. Then there is DBT, dialectical behavior therapy. How does that differ from CBT?
DBT was originally developed by Marsha Linehan to treat borderline personality disorder and individuals struggling with chronic suicidal ideation and self-harm. It incorporates elements of CBT, but it adds a profound focus on validation and specific skills training.
The texts mention distress tolerance as a key module there. What is that?
Distress tolerance is revolutionary for patients whose emotional pain feels intolerable. Instead of trying to immediately change the emotion, DBT teaches you how to physically survive the crisis without resorting to destructive behaviors like self-harm or substance abuse.
How do you survive it, practically speaking?
It uses physiological tricks like holding ice cubes or splashing freezing water on your face to activate the mammalian dive reflex.
The dive reflex, like when you jump into cold water.
Yes. This reflex forces the parasympathetic nervous system to abruptly slow your heart rate, allowing your prefrontal cortex to come back online and override the panicked amygdala.
That is a direct biological hack to stop a behavioral crisis.
It is entirely mechanical and highly effective.
I want to pivot to EMDR, eye movement desensitization, and reprocessing. Because reading the guidelines on EMDR for trauma and PTSD, it sounds bizarre.
It does sound unusual at first glance.
You're telling me that a patient tracks the therapist's finger moving back and forth with their eyes, or holds buzzers that alternately vibrate in their hands while holding a horrific traumatic memory in their mind, and this is a first-line empirically backed treatment. How on earth does moving your eyes reprocess trauma?
If we connect this to the bigger picture of how memory networks operate, it begins to make perfect sense. Trauma is not stored like a normal narrative memory.
How is it different?
A normal memory is processed by the hippocampus, time-stamped as in the past, and filed away. But during a severe trauma, the sheer volume of stress hormones short-circuits the hippocampus.
Sure.
The memory gets trapped in the amygdala, the brain's raw fear center, entirely unprocessed, with all its original visual, auditory, and emotional intensity.
So when a person with PTSD is triggered by a loud noise, their brain doesn't think, I am remembering a war. Their brain thinks, I am in a war right now.
Exactly. The memory is stuck in the present tense. The mechanism of EMDR relies on taxing the brain's working memory. Working memory has a very limited capacity. When the patient is forced to focus intensely on the bilateral stimulation, the eye movements back and forth, which closely mimic the neural activity of REM sleep, it takes up a massive amount of cognitive bandwidth.
While the brain is distracted by tracking the movement, the patient is asked to bring up the traumatic memory.
Right. Because the brain is dual processing, it cannot dedicate enough resources to summon the full, devastating emotional intensity of the trauma. The memory loses its visceral charge.
That's brilliant.
The bilateral stimulation essentially unfreezes the neural pathway, allowing the hippocampus to finally process the memory, timestamp it as in the past, and move it to long-term storage. It transforms from a present tense threat into a historical narrative. You still remember it, but the physical terror is gone.
That is phenomenal. It completely changes the definition of therapy from talking about your feelings to active, targeted neurological rehabilitation.
It really does.
But it's also critical to note that the guidelines do not view the patient in a vacuum. The deep dive into therapy strongly emphasizes systemic and family interventions.
We cannot treat the patient while ignoring the environment they return to every single day. For children with neurodevelopmental disorders like ADHD or autism, parent management training is often as important as the child's therapy.
Because you're changing the ecosystem they live in.
You are teaching the parents how to structure the environment to accommodate the child's neurological hardware.
And the data on family intervention for severe psychotic disorders is incredibly compelling.
It is one of the most powerful statistics in psychiatric care. For families dealing with a relative's schizophrenia or bipolar disorder, providing the family with intensive psychoeducation, teaching them the biology of the illness, how to communicate without high expressed emotion, and how to spot the subtle early warning signs of a relapse, directly and drastically reduces the patient's hospitalization rates.
You are building a localized safety net around the patient, which transitions us perfectly into our final pillar. We've talked about the pills and we've talked about the clinical therapy, but a patient only spends, at most, 1 hour a week in a therapist's office. What happens during the other 167 hours of the week?
This is where psychosocial interventions and holistic ecosystems become the glue that holds a multimodal treatment plan together. The World Health Organization guidelines heavily promote interventions that scale far beyond the confines of a psychiatrist's clinic.
We need community-based support to sustain recovery.
Absolutely.
The sources outline a massive expansion in how we deliver care, starting with the explosion of digital telehealth.
Telepsychiatry and digitally delivered interventions have fundamentally altered the landscape of access. The WHO specifically highlights internet-based CBT and structured mental health applications for scaling anxiety treatment and early suicide prevention.
So bringing the clinic to the smartphone.
Yes, for a patient living in a rural area or someone whose depression makes leaving the house impossible, having a therapeutic intervention available on their phone is a life-saving bridge.
But the clinical summaries argue that true holistic care has to go even further, addressing the foundational social determinants of health. We are talking about sleep hygiene, exercise, and nutrition.
You cannot separate the brain from the body it lives in. We know that cardiovascular exercise promotes the release of brain-derived neurotrophic factor, or BDNF, which literally fertilizes the growth of new neural pathways, complementing the effects of SSRIs.
And sleep is non-negotiable.
We know that sleep is when the glymphatic system flushes metabolic waste from the brain. If you are chronically sleep-deprived, your emotional regulation centers just degrade.
The guidelines also list housing stability and vocational support as recognized components of psychiatric treatment.
Because you cannot medicate away the profound chronic stress of not having a safe place to sleep. You cannot out-therapy the anxiety of deep poverty.
Right.
Helping a person with severe mental illness find secure housing or utilizing supported employment programs to help them maintain a job are medical interventions. They stabilize the environment, which stabilizes the cortisol levels, which stabilizes the brain.
And one of the most insidious barriers preventing people from accessing any of this care, whether it's housing, medication, or therapy, is the societal judgment we discussed earlier. Stigma. In our sources, there is a distinct, emphatic note about the power of language in mental health.
Words dictate perception, and perception dictates behavior. The guidelines explicitly instruct all providers and public health advocates to use person-first, non-stigmatizing language.
Let's define what that looks like in practice.
It means saying a person with schizophrenia rather than calling them a schizophrenic. It means saying a person experiencing a substance use disorder rather than calling them an addict.
You are intentionally separating the person's identity from the pathology of the illness.
Yes. You would never call someone a cancer. You would say they are a person battling cancer. Mental illness must be framed with the exact same objective, medical compassion.
That makes total sense.
Furthermore, the guidelines are clear on how we discuss crisis. We say someone died by suicide instead of saying they committed suicide.
Because committed implies a crime.
Exactly. The word committed carries heavy, outdated criminal or moral connotations. It implies a crime or a sin rather than the tragic outcome of a terminal psychological crisis.
Reframing the language removes the shame. And shame is what keeps people suffering in silence. Recognizing that you have a biological or psychological vulnerability and taking the steps to seek therapy or utilize medication is an act of profound courage and self-awareness. It is the active management of your health. It is the absolute opposite of weakness.
And stripping away that stigma is critical so that when a crisis inevitably hits, people are not afraid to reach out. Because we must take a moment here to address crisis management directly with you, the listener.
Absolutely. This is crucial.
The clinical protocols are unequivocal. You must always take talk of self-harm, hopelessness, or suicide seriously. If you or someone you care about is experiencing active suicidality or a severe mental health crisis, immediate intervention is required. Do not try to manage an acute, life-threatening psychiatric emergency alone.
There are practical, immediate resources available globally. If you are in the U.S., you can call or text 988 to reach the Suicide and Crisis Lifeline. In the UK and Ireland, you can contact the Samaritans at 116 123. In Australia, Lifeline is at 13 11 14. Almost every country has a dedicated 247 emergency number for mental health crises.
Please reach out to them. They are not just listening ears. They are staffed by professionals trained in evidence-based de-escalation.
And they can help you build a plan.
They will help you build a concrete safety plan, identifying triggers, listing coping strategies, and removing access to lethal means, and they will connect you with immediate local psychiatric care.
So what does this all mean? If we step back from the cellular mechanisms, the neurotransmitters, the therapies, and the statistics, what is the core narrative of this deep dive? It means that mental disorders are incredibly fundamentally common. They affect over 1 billion people.
They are an intrinsic part of the human experience.
Yeah. They are not character flaws. They are complex conditions driven by the intricate dance between our genetic blueprints and the environments we inhabit. But most importantly, the resounding conclusion from all of these clinical guidelines is that they are highly, highly treatable.
That is the enduring message here. We are not helpless. Through personalized, multimodal approaches combining the precise pharmacological tools to stabilize the biology, targeted therapies like CBT or EMDR to restructure the cognition, and strong, compassionate systemic support to heal the environment, people do recover.
It's not always a straight line, though.
The trajectory of recovery is rarely a perfectly linear path. There will be relapses and setbacks, but functional healing, stability, and a deeply fulfilling life are absolutely possible.
Knowledge is the antidote to fear in this space. By understanding the neurobiology, by understanding the mechanics of the treatments, we strip away the shadows. We normalize the conversation.
Whether you are managing your own emotional well-being or supporting a loved one, early intervention, education, and relentless compassion are the keys that unlock the door to recovery.
I want to leave you with a final thought to ponder, something that builds on the mechanisms we've explored today. We spent a lot of time discussing epigenetics, how chronic stress, trauma, and a hostile environment literally reach into our cells to alter our gene expression and shrink the hippocampus.
It's a powerful mechanism.
So, if the environment is pulling the trigger on our biological vulnerabilities, what happens if we stop solely focusing on treating the individual after they become ill? Could society eventually shift its resources to proactively design our schools, our corporate workplaces, and our urban centers as preventative mental health ecosystems?
That is an incredible thought.
If we know the precise environmental factors that break the human mind, don't we have an obligation to engineer an environment that protects it?
It is the ultimate paradigm shift, moving from reactive clinical medicine to proactive, systemic psychological wellness.
Something to mull over as you navigate your week. Keep asking the hard questions, keep challenging the stigmas you encounter, and above all, take care of your mind and the minds of those around you. Thank you for joining